This week on the Backtable podcast.
I think it just is important to recognize that inflammation doesn't just stuff up your nose. It kind of like rewires your brain. And I think the more we understand how the brain and inflammation is connected to each other, I think the more we'll understand that this condition actually is a whole body condition and a whole life disease. And I think that that's something that I hope that folks who are listening in will appreciate. I think we already kind of appreciate that when we talk to these patients, but recognizing it as a real thing and telling patients that this is something that is a component of the condition and making sure they're heard can be really powerful.
Hey, everybody, and welcome to the Backtable ENT podcast. My name is Gopi Shah. I'm a pediatric ENT, and I am across the mic with my co-host partner in this awesome endeavor and dear friend, Dr. Ashley Agan. How are you?
Hello, good morning. I'm so good and so excited. We're talking about sinusitis and cognition and brain fog today. So if that's something that you've seen in your practice and you are curious about, then this is going to be the episode for you. We're very lucky to be joined by Dr. Aria Jafari. He's an assistant professor at the University of Washington and is the co-director of the Neuroendocrinology Advanced Sinus and Skull-Based Surgery Fellowship there. And he's doing some really exciting research on sinusitis and cognitive dysfunction. Welcome to the show, Aria.
Thanks very much. Good morning, Gopi and Ashley. It's great to be with you.
Can you tell us a little bit about yourself and your practice?
Sure, I'd be happy to. I'm a West Coast native. Did my med school at Stanford and my residency at UC San Diego, then headed out east for my rhinology and endoscopic skull-based surgery fellowship at Mass Eye in Boston. And I've been in Seattle at the University of Washington ever since, going on 5 years now, where I practice the full spectrum of rhinology and endoscopic skull-based surgery with some amazing folks here. I have a particular clinical interest in endoscopic orbital surgery and a research interest in outcomes with particular interest in cognitive outcomes in patients with sinonasal inflammation.
How did you find your way to that particular research, that kind of research, And I mean, I guess, in my mind, a lot of things come from our experiences with patients. And so I'm just imagining, as you're seeing patients, you're kind of noticing, wait a minute, everybody's talking about brain fog.
Why is everybody so out of it in my clinic?
That's a good question. You're absolutely right. I think it's about, it all starts with your interaction with patients. And I think for me, I think the seed was planted probably in medical school where I was trying to decide on a specialty and, I had a strong interest in the neurosciences and was thinking about neurology in terms of a specialty or neurosurgery. And, I took an ENT rotation kind of because I had to as part of the rotation package that I had to do for general surgery. And it was interesting in that experience, I think all of us can relate to this, I was just taken aback by the human experience that's associated with the conditions that we treat. I felt like the conditions were not just a sinus condition, but a whole life condition, and being able to kind of influence that or help patients navigate that seemed pretty powerful. And so, to be honest with you, I think it kind of that part of it kind of went into the back burner as I kind of dived deep into residency and residency training. And then I think eventually, subconsciously, I got drawn back into it through rhinology fellowship. But I think it wasn't until my fellowship year where one of my fellowship mentors and my fellowship director, he had this way that he interacted with patients that was a little bit different than I had been used to. He taught us not just to ask about their sinuses, but to really ask and understand who the patients are and what they do for work, what their lives are like. And that deeper connection led patients sharing about how CRS was impacting them in ways that I didn't often think about. And so I kind of was surprised by that. And I kind of started thinking more and more about that. And folks would share really intimate details about their lives, about how they, were embarrassed on a Zoom call because people kept asking them if they were sick, or they weren't able to show affection to their partners because their nose was too stuffed up, to kiss their spouse, or they're struggling to do basic tasks like paying bills, or they would forget their keys. And, it's something that I didn't really expect in a sinus clinic. And so that's kind of where it started. I started thinking about it more, and, I approached a mentor of mine in fellowship, and I said, hey, I want to do a research project. It would be kind of a research project that I had been more familiar with in the past, maybe an outcomes project or, basic science project or something like that. And that particular mentor actually turned it back onto me and said, why don't you send me 3 research ideas and we'll review them together and we'll go from there. And so I sent kind of 2 ideas that were kind of more run of the mill. And then I threw this one idea that was totally off the wall. And I was like, you know what? I think we should study patients with sinusitis and look at brain fMRI and see if there's a difference in brain activity, because clearly the behaviors that patients are expressing, that what they're experiencing is different. And I thought he would say, this is crazy, no way. But he said, this is a great idea. We should do it. And from there, he connected me with some amazing people, amazing collaborators at the Mass Eye and Ear and beyond. And we were able to do one of the first functional imaging studies looking at how the brain can change in states of sinonasal inflammation. So anyways, it's kind of a little bit of the journey. And then since I've been here at the University of Washington, we've continued that in a lot of different ways and tried to study it as best we can.
I love that. So much serendipity in your story. Just so fun. So as we start to talk about how sinusitis and brain function and cognition all kind of intersect, can we just start by talking about things that you've kind of alluded to with your patients? So overall quality of life impact for patients with CRS. And are we talking about all comers, CRS with polyps, without polyps, some mild mucosal thickening,
is it like just in the elderly? Like who is this? And yeah,
it's a great question, and it's, from my experience, it is all comers. It's the CRS with polyps, it's the CRS without polyps, it's the minimal disease patient, it's the maximal disease patient, it's the young patient, it's the old patient, it's the high functioning patient, it's the patient who's struggling. It's kind of, I think it spans the spectrum of all the patients that I treat, and it's no surprise to a lot of us that CRS is super duper common, 10 to 15% of the population. But I think it's not just about being common, it's about how deeply it impacts the patient's lives. And when you start, all I do is nose and sinus disorders in my clinic. And so I see this 20, 30 times a day. It's more than just a stuffy nose. Imagine having a cold that never goes away. And that cold slowly invades every corner of your life. And so I think it's not surprising to me, maybe other folks who are listening in, that when we look at quality of life impact and compare it to other common diseases like congestive heart failure and COPD and asthma and Parkinson's disease, CRS is right on par with those. It highlights the fact that this is so impactful. And another measure that I think is pretty helpful in terms of understanding what our patients are experiencing relative to other conditions is something called a health utility value. And this is something that was introduced to me through Tim Smith and his group and his work in this topic. And it's basically, a health utility value is basically how people rate their own health on a scale of 0 to 1. So 1 is perfect health. And I was just surprised that CRS, the score for patients with CRS is 0.65. So this is on par with end-stage renal disease on dialysis and Parkinson's disease. And again, I think it just highlights how deeply CRS can reach into every aspect of health. So it's not just a physical condition, but it's also a mental and an emotional one too. And so, on top of that, we spend millions and millions of dollars, $10 billion a year managing it, perform 500,000 surgeries. The patients incur a huge cost in addition to what they experience. It's financially, they can experience, a loss of about $7,500 a year, higher in patients with nasal polyps. And that's the cost of medications, lost work productivity, something called presenteeism, where you're at work, but you're underperforming. Anyways, just a huge amount of expenditure and cost to society and patients themselves. So anyways, when I talk to patients, I always like to ask this question, which is, obviously we ask the cardinal symptoms. We ask, facial pain and pressure, discolored nasal drainage, nasal obstruction, and loss of sense of smell. But I always like to ask, how is this condition affecting your life? And I think you'd be really surprised to hear what people say. And so, we hear that poor sleep, fatigue, that comes up over and over again. And we know that patients with CRS are twice as likely to have poor sleep and much more likely to be depressed, but increasingly recognized as this component called cognitive dysfunction or brain fog that keeps coming up. And when I talk to patients and kind of probe that, and I think that's really fascinating and I think requires a lot of our attention, because it's really those non-nasal symptoms that drive patients to seek care, number one, but also to make medical decisions, specifically escalating treatment and deciding to undergo endoscopic sinus surgery. So there was a really interesting study that showed that patients who have a higher psychological domain within the SNOT-22, which is our sinonasal outcome test, if we look at the psychological and sleep components of that test, folks who tend to score higher on that dimension of it tend to elect surgery more so than folks who have a lower score on that. So anyways, I found that that's kind of interesting and impactful and important for a lot of reasons, including how we treat patients and the treatments that we offer patients.
So Aria, you have an example of a patient describing their symptoms to you specific to brain fog. Do you mind sharing that with us?
Cool. Yeah, no, this was a patient of mine that I actually met with last week, and I knew I was going to be with you guys today, and so I just asked if he'd be willing to share his experience with sinusitis and how it's been affecting his life. So yeah, let's go ahead and play it.
I think the biggest issue when I do have these sinus infections or sinus issues beyond the congestion and the facial pain is really the brain fog really interferes with the daily life for me. It really puts me in a situation where I can feel it coming on. I really have a hard time concentrating and focusing on things. And I think that's the biggest issue for me is when you're constantly fatigued and you're mentally fatigued for some reason. And you're trying to figure it out and trying to work. But I think it's one of the biggest impacts of the issue for me is the brain fog really stops me from being productive. It really have to slow things down, kind of impacts the way of me thinking, slows my thinking capabilities quite a bit. And I feel like in a separate person when I have the brain fog. That's the most interesting thing. Once I have it bad, you don't recognize yourself. Kind of you're like, what's going on? Like it's probably the only time of the year where I take sick leave out of work. It's very interesting. Like it's the only time when I get a sinus infection that it affects my work like that. I just have a daughter. It affects me that in just terms of interaction. You just don't feel yourself. I think it's the hardest thing to deal with.
Man, there's so many things that your patient says where I'm like, oh my God. It's like, yeah, I get brain fog, but when he says, oh, I can feel it coming on, like it slows my thinking, it affects him with his daughter. I'm like, wow, this is more than just the studies that you're like, oh, work productivity and these things that you just kind of, like a checkbox, like this, it's so much more profound.
Totally. Yeah. And it's like in 1.5 minutes, like you can learn so much about how this condition is affecting them. And I think it was like those questions were often like a little uncomfortable to ask because we don't know what they're going to say. And, when it's beyond kind of like you said, like the checkbox,
runny
like
nose.
the runny nose, we're trying to make the diagnosis but you learn so much. And yeah, there's things in, like you mentioned, like the mental exhaustion of it all. And I think that really strikes me. And that's a theme that I keep seeing with my patients. They're just like, it's like so much at the forefront of their lives. Like everything they do, they have to power through the brain fog first to do whatever they need to do. And it gets tiring and it's exhausting for a lot of them. And it's important to recognize it. I think patients, like they're just acknowledging that dimension of their condition is really powerful. I think people really feel heard. And I think it's a nice way to just like fully understand the impact.
How long does it last for? So you have a patient with CRS, right? And so we're thinking this is now months of having sinonasal symptoms, weeks. But the brain fog, is that something that comes and goes? Is that something that's kind of around just like this whole time?
And can we also define brain fog since it's more of a patient term than than our term?
Absolutely. Yeah, exactly. So brain fog is kind of like a colloquial term. I think there was like a Reddit study that asked or like reviewed Reddit posts and they looked at posts that were looking at brain fog or mentioned brain fog. And the most common themes that people described were things like forgetfulness and difficulty concentrating, cognitive slowness, and problems with communication. So it's really like an umbrella term. It describes a collection of symptoms rather than a single problem. Again, difficulty with planning, organizing, making decisions, finding words, learning, remembering. And in even severe cases, it can affect personality. And I think the clip that we played, I was surprised to hear like he felt like he wasn't himself. And that's actually, again, a common theme, that they feel like it's like a out-of-body experience. Like they're not who they want to be or they typically are. They're not as sharp. They're not as witty. They can impact their relationships, their social interactions. They're not wanting to go out to dinner, they interact with their friends. They're wanting to stay at home. And so yeah, I mean, I think the brain fog term is, like you said, a kind of an umbrella term, a little bit of an ill-defined term. Cognitive dysfunction is a little bit more specific because it discusses kind of more precise brain networks, brain components that go into how we think and go about our daily lives. So, but yeah, I think it's important to know that not every patient with sinusitis has brain fog. So I think that's one thing that I think we should just discuss kind of off the bat. You know, we did a study and about 50% of patients that come through our clinic who have a diagnosis of chronic rhinosinusitis end up having some form of at least mild cognitive dysfunction when they were administered a test. It's called the NeuroQol NIH short form 8-question test. And so it's kind of like a screening test, and it has population norms, and I was surprised to see half the patients actually were below the population norm for cognition. And about 1 in 6 actually had severe cognitive dysfunction, which was like 1.5 standard deviations from the mean. So that's a pretty impactful, pretty big number.
Is that test asking them, like, how well do you feel like you can do these tasks? Or is it actually like giving them a test and making them think? And you know what I mean? Like, are there right and wrong answers on that test?
Yeah. There's so many tests that test cognition, and we incorporated this into our intake in our sinus clinic through a virtual format. And so we found that it wasn't something that needed to be administered by like a research coordinator or anything like that. So it's a Likert scale. It's like 1 to 5. And it asks questions like, tell us, you know, how often this occurs. And one of the questions is like, my thinking is slowed. It seems like my brain is not working as well as usual. I have trouble concentrating. I have trouble like adding and subtracting numbers in my head. You know, those are some of the questions that we ask. And so, yeah, but yeah, there's a lot of different tests that we administer, and we've done different types of tests, more like objective tests as well, instead of subjective tests where the patient reports it, and more things that we're able to measure more objectively as well. But this was just surprising to see the sheer number of patients who have trouble with this kind of daily functioning. And then I also asked the question, like, what about patients who just have like nasal obstruction, like their nose is blocked, maybe they're seeking care, you know, how do they do on this test? And there's a decent amount of patients who also have or report cognitive dysfunction. About 10% of patients with obstructive pathology alone also have some sort of cognitive dysfunction. And then overall, it's just much higher in these sinonasal patients than the average population.
So for the neurocognitive screen that you give, you use it for research, but as well as to kind of better understand what your patients are going through. Do you then ever like use it to then refer to like neurology, or do you get functional MRIs as part of, you know, like how do you then, if there is somebody that's really scoring or you're concerned, I don't know what I'm trying to ask you, but yeah, what do I do with that information? When do I clinically have to like
change management?
Yeah, or when do I
Yeah.
clinically have to then include like neurology?
Other specialists and things like that. Yeah, totally. I think there's, you know, the screening test is one way to kind of better understand folks and their cognitive ability. But, you know, even the SNOT-22, like I had mentioned, has domains that include questions about concentration and cognition. And so there's a psychological domain score that can be easily calculated. And we also look at that to figure out, you know, how much that component of the condition is contributing to the overall burden of disease. And so, you know, that also raises my suspicion for cognitive dysfunction, you know, even if we weren't administering this screening test. And so I think you take all the information like we do, you know, with any patient, and we kind of process it. And so I think if the condition is coincident with sinus flares or their sinus condition overall, I think that you can have a conversation with the patient and say, hey, you know, does this ever get better or worse? Is this fluctuating? You know, similar questions that I think I ask my patients with like smell loss. Like, is this something that's coincident with some of the other sinus conditions, symptoms that you have? And does it ever get better with treatment like prednisone or nasal irrigation or that kind of thing? And if they say, oh, yeah, when I'm feeling good, you know, I'm totally sharp. I'm ready to go. I'm at work. I'm on top of my game. But, you know, when these symptoms flare up, you know, I really feel it. And to me, I feel like that is probably more connected to the sinus condition, and I think can be managed by us as otolaryngologists. But I think if this cognitive dysfunction is significant, like I dig a little deeper, I ask about tremors and memory loss and weakness or other neurologic changes. And, of course, if there's anything there, then I would refer to a neurologist and help them figure out if there's like a separate like neurodegenerative process going on.
I would assume that's pretty rare. You're probably not
Pretty
diagnosing a ton of like neurodegenerative problems, right?
Right. Yeah, I would say like once a year, maybe I come across a patient where they have something more concerning or worrisome, and I'd have to send them to neurology for formal neuropsychiatric testing. And what's cool is the neurologists actually know that we're doing some of this work. And so I actually get the more referrals in the other direction, which is like kind of surprising. You would never think like a neurologist would refer to a sinus surgeon.
They're like, rule out sinusitis.
So funny. And they get tons of imaging, and they get, that polyps are coming, all over in the MRI scan. Then they're like, hey, maybe we should check this out. They kick it back to us. So I actually think the referrals go more in the other direction.
That's a great partnership. Before we move past, talking about tests, you had sent us an example of the Stroop test. And so basically, or I'll let you kind of describe what this test is.
Yeah. So, we were just talking about neuropsychiatric testing. So among kind of the battery of neuropsychiatric tests, one of the kind of oldest tests that neuropsychologists administer to patients is something called the Stroop test. And it tests interference. So like if you have like a distractor in your environment, how much are you able to focus on the task at hand and to execute the task at hand while you're distracted by something else?
So basically the Stroop test is every day in my house. It's like every day.
Exactly.
Okay.
Yeah.
It's real life.
It's trying to. It's trying to.
I'm just going to tell my kids,
world.
yell more. I got to make sure I can finish this task. It's challenging my mind here. This is good.
Totally. Yeah. And what's interesting is the sinus patients actually do overall okay on like basic tasks. So I think that's also important to know. These patients aren't like having, a significant amount of reaction time issues or kind of more of like the simple types of tasks. They're actually having issues with a little bit more of like the higher level tasks, which require more attention or more brain functioning. And so Stroop tests that. And so folks at MUSC administered this test to their patients, and they wanted to see the impact of medical therapy on cognitive dysfunction in chronic rhinosinusitis. They found that the reaction test, the Stroop reaction test, which is basically a series of words that are in colors. There'll be like a red word. It'll say red, but it'll be in red color. And then there'll be like a green word, and it'll be in green. And then they'll administer that, and then they'll administer the same words, but the colors will be switched in the word. So it'll be listed as green, but it'll be red. And they'll ask the patient to say the color and not the word. So they found that patients with chronic sinusitis actually struggled with that because it's hard for them to get past the fact that the word green is actually in red color. But that actually was interestingly also something that improved with medical treatments.
And they're just checking to see if they get it right. Is it timed? Like, do you need to be able to do it fast? Because as I'm sitting here looking at it, I have it pulled up. And,
green, red, blue.
If I take my time, I'm like, okay, red, green,
it's
yellow,
a time thing.
blue. But if I tried to go
tired.
faster, I think I would miss more.
Totally.
Or it slows down after 3. I'm like, oh God, come on.
It's a tough test, actually. It's super tough. But yeah, it's a time thing. So they'll time it. And then if it takes longer to get it, then they'll record that.
These things are kind of fun because it's interesting to see how your brain tries to just do things faster or to kind of do things without thinking, and then it's like the wrong thing, or kind of similar to those paragraphs where they leave out most of the word, but if it has the first letter and the last letter, your brain will just kind of fill it in and read it. Like, it's just fascinating. Yeah, super fun.
So do we understand any of the pathophysiology? Like, is there a pathophysiology or, something now that we're saying, hey, there's a link here? Do we know why?
Yeah, so that's a great question. And I think the honest answer is probably we don't fully know yet, but we have some strong theories. So I think the two leading ideas are, one, could this be like a neurodegenerative process? Are we speeding up like Alzheimer's disease or something like that? Is chronic inflammation causing neurodegeneration? And then the second theory or idea is chronic inflammation triggering neurohormonal changes that affect cognition. And I would say that the preponderance of evidence actually supports the second theory, which is that there's like a neurohormonal change that kind of changes the milieu within the brain and changes the brain functioning based on the inflammatory response that is present in CRS, but also many, many other conditions. And so we did a study and we looked at neurodegenerative markers in spinal fluid in patients who had sinus inflammation, and we didn't see any difference. And that kind of supports the fact that, it's probably not cell death. It's probably just dysregulation. And clinically, we also see that, like I had mentioned, the patients will fluctuate in terms of the severity of their cognitive fog, and that's usually coincident with the level of inflammation. So, what is neuroimmune or neurohormonal? What does that pathway look like? Well, I think we all kind of experience it and know it on a personal level. Like if you cut your, skin with like a paper cut, it feels warm, it could be tender. Those are inflammatory cytokines that rush to the site to help us heal. And in CRS, we know that there are cytokines like IL-1, IL-4, IL-6, tons of cytokines, and they feed signals actually back to the brain to regulate the immune process. And so, cytokines aren't just these factors that cause physical symptoms like fever and body aches and redness, that kind of thing. They actually are increasingly known to cause like behavioral changes, and that's called sickness behavior. If you ever had like a bad cold or a flu, you kind of know what that means, right? Like you don't want to do much. You want to hang out at home, maybe not socialize. It's actually an evolutionary adaptation, we think. So when your body is fighting an infection, it wants to conserve energy. We only have like a certain amount of energy and calories. And so your body kind of like turns everything down in terms of the non-essential activities, including higher cognitive processes. So if you think about like the last time you were sick, you probably felt withdrawn or tired. You had trouble concentrating and maybe like felt a little depressed. And that's actually your immune system deliberately influencing your brain to prioritize your healing. And so, it's crazy because I always thought, blood-brain barrier, in medical school, but turns out there's more of a communication than we think. The immune system communicates with the brain through structures like the choroid plexus. It's like this fluffy material within the ventricles, and it regulates like what can pass. And one of the things that can pass is actually cytokines. And so when inflammation is like prolonged, like it is in sinusitis, but also things like inflammatory bowel disease or even like obstructive sleep apnea, when it becomes like this persistent state, the inflammation can actually, and the cytokines can actually influence the neural signaling within the brain. And so there's even like animal studies that back this up. I think, I don't know, this kind of is a funny one, but it kind of at a basic level tells me that there's probably some component of our immune system that influence our behavior. So like reptiles, like there's a study of iguanas, and every time they get sick, they like seek out sunlight to raise their body temperature because they're cold-blooded. And so that's just at a basic level, it's like their behavior is changing to promote their survival. And I think for us and states of chronic sinus inflammation, that's also happening, which is kind of crazy.
So these cytokines are probably traveling to the brain through the bloodstream. It's not because if it's happening, in IBD and other things, it's not necessarily because the sinuses are,
Right
close to the brain. It's traveling through the bloodstream and affecting behavior in that way.
Yeah,
Maybe.
Totally. Exactly. That's what we think. So yeah, things like sarcoidosis, they found that like if you treat it like medically with TNF alpha, it improves disease control, but it also improves cognitive function. And then in like conditions like sickle cell anemia, where the sickled cells trigger an inflammatory cascade, the increased levels of interleukins correlate with the disease, the inflammatory state, but also the cognitive functioning of those patients. And again, inflammatory bowel disease is the same thing. So it actually is probably through the bloodstream and not like a direct effect.
Have we found any links between a patient on biologics? And I mean, I would imagine if I'm on biologics for nasal polyps, I'm going to feel better because my nose and sinuses have less inflammatory mucosal disease. I can breathe better. But do the biologics affect the cytokines in my brain to then make that neurohormonal shift that may have occurred with my brain fog go back to the baseline? Like, are we seeing that?
It's a great question. I don't know of any studies that have specifically looked at that. Thanks for the idea, but it would make sense, right? I mean, we're directly impacting these signals, and so we would expect that the brain fog would improve. And I do know that when we look at quality of life overall, the SNOT-22 I know is a commonly used measure of disease control, and studies that have looked at biologics, dupilumab, and others. Obviously, patients are improving quite a bit on their SNOT-22 if it's particularly dramatic in certain domains or in cognition. I don't know the answer to that, but it'd be interesting to further dive into it.
And when you did the study with functional MRIs, which are more looking at like activity, but the brain essentially looks the same. You're not seeing like long-term like brain changes. It's just the brain is functionally working differently because of these inflammatory mediators.
Yeah, exactly. So yeah,
Okay.
the brain isn't like, we don't think that there's like a degenerative process. We just think that the networks are just firing differently in the states of chronic inflammation and more shifting towards kind of that introspective, what we call the default mode, where you're kind of like self-ruminating, and those connections are actually strengthened. And then the connections to what we call the salience network, which is like being like alert and ready to act, those are decreased. The connections to those brain areas are decreased.
Now, going back to like risk factors. I know we're like kind of at the testing and pathophys, but patients who have like a history of OSA or depression, and now they have like CRS, are those patients going to be at higher risk for having cognitive dysfunction? Or how do you know it's the CRS that's worsening their baseline?
They have like multiple reasons, multiple
Yeah.
hits.
Like how do I know? Like, and maybe does it matter? Because maybe if I'm rinsing my nose and clearing my sinuses, I'm overall feeling better. I don't know. How do you think about that?
It's a tough question. So right now, I think we don't know a lot about the specific risk factors for cognitive dysfunction and CRS. Part of the challenge is we don't really fully understand the immunology of CRS to begin with, and we also don't really understand cognition to begin with. So it's like two things that we don't really fully understand, and it's still a black box in many ways. So combining the two makes it even more complex. But I think one of the things that has borne out in our literature kind of time and time again is like the level of inflammation. So can probably put you at a greater risk for cognitive dysfunction. So that's because the studies have shown that chronic rhinosinusitis with nasal polyps are primarily driving a lot of the cognitive effects. And those patients we think of as having a more significant amount of inflammation in the nose. And it kind of fits with the overall theory of why we think this is going on. But yeah, to answer your question about like other risk factors, I used to think maybe it was folks who didn't have a lot of cognitive reserve. There's been some studies on, high IQ patients who are able to compensate for neurodegenerative issues or traumatic brain injury. But my experience actually doesn't seem to fit with the cognitive dysfunction seen in chronic sinusitis. The clip that we played earlier was a patient of mine's an executive, and actually he's performing at like a high level like all the time. And when it dips just like 1%, 5%, he's feeling it. He can't perform at that level. And so I'm not quite sure if the cognitive reserve kind of theory about compensation actually applies to this patient population, because our patients are so typically high functioning, usually middle-aged, working, and they feel it more because they have to be on top of their game to kind of function and be present at work. So yeah, and I had mentioned, patients with chronic nasal obstruction, which we study, also have some cognitive dysfunction at a much, much lower level. And so there may be some component there that is contributing. And one of the really surprising findings when I was doing this research and trying to understand similar conditions that had similar patterns of cognitive dysfunction was obstructive sleep apnea, which turns out is actually a chronic inflammatory state as well. And those patients also experience cognitive dysfunction. And this is all layered in by, the sleep disturbance. And so many of these studies have actually corrected for hours of sleep or sleep quality, and they still see the cognitive dysfunction kind of borne out. And it's because that the immunologic basis actually disrupts sleep centers as well. And so it's all kind of interrelated, interconnected. It's tough to figure out, specifics in terms of like risk factors, but I think overall it's probably our high inflammatory burden patients that bear the brunt of it.
Yeah, that makes sense.
Do the patients with CRS who have olfactory symptoms have a higher risk of having, quote, brain fog or cognitive dysfunction? Have you noticed anything like that? Because I just think of like anosmia and as an early sign of potentially Alzheimer's, like, right? That's kind of realizing that I know that by itself is different than CRS, but smell and olfaction plays a role in CRS too.
Yeah, totally. I think obviously smell loss has gained a lot of attention, through the COVID pandemic, and that's borne out a lot of really interesting research to help us better understand the relationship. And one of the really fascinating things that I love about the olfactory nerve is it's one of the few cranial nerves, the only cranial nerve that interacts with the external world. So it's in our nose and it transmits it directly to our brains, and it bypasses the brain stem. And so we can learn a lot about that processing. We don't think that inflammation in the nose is traveling in that direction through that nerve, but again, we don't know for sure yet. We do know that inflammation can shut down that nerve, and we know that when that nerve is shut down, our brain is deprived of that sensory input. So similar to like hearing loss, and if there's sensory deprivation, that can affect cognition potentially. And so there's a sensory deprivation hypothesis, the idea that losing some sort of sensory input like smell can cause downstream degeneration in brain areas that depend on that input. But I think it's probably two separate processes and not directly related, and not as simple as kind of going from the nose to the brain through that mechanism.
But also patients that are having anosmia probably have a higher disease burden if they have that many so it kind of goes along with your point earlier that it seems to be patients who have more inflammation, higher disease burden, maybe are more likely to have the cognitive dysfunction piece.
And I think the duration also matters, something that we haven't chatted about yet. So folks who have had inflammation for a longer period of time tend to have worse cognitive dysfunction, and that's been shown in other studies as well.
And so as we think about taking care of these patients, treatment, whether it be medical, surgical, combination, biologics, all the things in our tool belt, do we expect patients to have, I assume you probably do like pre and post, and like you're kind of following their cognitive function. Like, what are you seeing in that regards? Like, is it usually, you had mentioned, fluctuating symptoms earlier. So if we can get things under control, can we promise patients that they can be brain fog free?
Yeah, I think I always like to kind of see how patients respond to medical treatment, and if their symptoms are going to respond to like steroids or intranasal steroids or oral steroids, I tend to think that maybe good control over their condition overall through surgical treatment or biologic treatment or whatever we're offering them will also have a similar benefit if it's truly related to the underlying inflammation. So we have that conversation together. And I think that, if they have strong benefit from the anti-inflammatory treatment, then the patient will have, it's more likely that treating them with surgery or medical treatment in general will improve their cognitive functioning. But I think that this all kind of plays into kind of this like X factor that I think about in sinus patients, where we have like the diagnosis and, working at a teaching hospital and we have residents and fellows, often they'll see my patients in the clinic. They'll go in and get a history and do an exam, and they'll come back and I'll always ask, what do you want to do? How do we want to treat this patient? We always have like kind of a guess when we go in, but sometimes when we go in, like based on what the patient tells us, that treatment plan completely changes, right? Because they're like, there's polyps coming out the nose, but they're not bothered by it at all. So, okay, we're going to do something completely different. So a lot of this is guided by the patient, how much it's affecting them, how much this condition is shaping their everyday life. But I will say in general, if cognitive dysfunction is part of their symptomatology in a significant way, it often pushes me to escalate medical therapy sooner. And if needed, offer surgery to regain better control over their disease.
So does that mean you're more likely to do budesonide rinses or oral steroid burst versus like if you're going to, when you say offer medical therapy sooner?
Yeah, exactly. So it's exactly right. I'm much more likely to offer a steroid burst and budesonide irrigations, and maybe even convert or offer surgery sooner, maybe than another patient that's not so bothered by that.
So you'll have patients who get better, like with their sinonasal, like the classic sinus symptoms and the brain fog. And then you'll have patients that maybe they don't respond with the sinus or the brain fog symptoms. What do you do with the patients that the sinonasal symptoms get better, their polyps are better, but they still have this brain fog? Do you get patients like that? Because for us, seeing objective, like, pus, swelling, polyps, we're like, okay, I have something but the brain fog, I guess
it's harder
maybe
to see.
Yeah.
Absolutely. Yeah, I think those are the patients that we start thinking about something else going on, honestly. And so those are the neurology patients where we'll collaborate with the neurologist to get their symptoms under better control or better understand or characterize their symptoms. I think the sinusitis can really cloud kind of the brain fog symptoms in those patients. And often they're much better, but they may not be where they want to be in terms of their cognitive symptoms. And so we'll have to collaborate with the neurologist to get a better sense of what's going on. And interestingly, practicing in Seattle, I see a lot of patients who often seek like complementary care through like naturopathy or acupuncture. And so I've actually learned about a lot of adjunctive treatments that treat brain fog, like acetyl L-carnitine, which has actually reasonable evidence to support cognition and acupuncture. I think there was a recent Nature paper that showed that it may help autonomic nervous system function and potentially help this patient group. So it's kind of like an all hands on deck kind of effort if they're in that small group of patients who are still looking for more benefit.
And so what's on the horizon? What are we going to learn, in the next 5 to 10 years about our sinusitis and our cognition?
Yeah.
Or what would you like to be seen? What studies do you want to, or do you want to be seen, or do you want to do? Yeah.
So I think one of the main things that is kind of holding us back right now is that a lot of our measures are kind of subjective. So we're asking patients to fill out a questionnaire, and someone is feeling miserable, they may fill out a questionnaire a certain way, and our SNOT-22 scores tend to track with our cognitive testing scores, especially when they're administered to the patient to self-report their condition. And so I think I'd like to see more kind of objective data, more objective research, shifting away from cognitive testing and questionnaire-based assessments, but maybe more towards what we've been doing recently, which is eye movement testing, which is like a low cost and a non-invasive way to assess integrity of brain circuitry. So our eyes and our brain are super tightly connected, and our attention is actually often very well measured by where we look. And so we've used it in our research recently, where we showed that CRS patients who have significant sinus inflammation compared to controls, they have deficits in terms of eye movements and attention. And we used different paradigms to assess that within that patient population. So I think more studies like that. I think that was like a CRS patient population versus control. I think it'd be really interesting to look at the CRS patients, treat them, whether it's surgery or medical treatment, and then retest those same patients using eye tracking and eye movement assessments. I think functional neuroimaging can be super helpful in this space as well. So I'd love to collaborate with experts in functional neuroimaging. It's really exciting, but it's also really expensive. So if anyone's interested in listening, reach out. We're happy to collaborate. But yeah, it's tough because neuroscience and this type of work, we can't just go in and kind of like sample their brain, or even doing CSF sampling is like super invasive. And so we do have to kind of find these surrogate tests to better understand what's going on.
With those eye movement tests, are you wearing the same goggles that they use for like vestibular testing, and the patient is tracking a dot on the screen, or what is it?
It's exactly the same. So yeah, I collaborated with our vestibular scientists, and we use like infrared eye trackers. So they're tracking a dot. So there's like 4 paradigms that we looked at, like one that's called like the prosicod. So there's like a dot in the middle, and then a dot appears off to the side, and then you just shift your attention. And then there's something called an anti-saccade, where the same thing happens, but the instructions are that you look opposite the dot. And so that's a little bit of a tougher test. CRS patients tend to do worse with that test. And then there's different kind of variations of that we are able to assess cognitive functioning. And so yeah, we wheel that machine into our clinic, and we pull patients in and do that test. And it takes about 30 minutes or so. And at the same time, we do some other cognitive testing with them. But yeah, I'd like to follow those patients more longitudinally to kind of better understand the impact of treatment on the functioning. And I think there's also some other interesting, super cool ideas that have come out in the literature. I think, what do we do about this? And I think folks who are listening may be like, okay, great. I have a patient with CRS. They have cognitive dysfunction. Maybe I'll do some prednisone, or, if they don't get better, what other options do I have? And so I wonder if approaching the neurocognitive component to CRS in a different way, in addition to kind of our classic sinus treatments, could offer additional quality of life benefits. So things like cognitive behavioral therapy or antidepressants or herbal supplements. I mentioned acetyl L-carnitine. Like, it'd be kind of cool to see if those patients do better after surgery, because we're specifically addressing that dimension of their experience.
Yeah, I was gonna ask you, like, what would be your take home point for all the ENTs listening? But I think that's, to your point, like, I mean, for me in kind of preparing for this and thinking about it, I think the big thing is just kind of having a better understanding of the quality of life aspect to it, right? Because I think, we're talking about, lots of lost hours of not only productivity, but like your patient talking about just time with their family, and like it can be a really big problem for patients. And so just understanding like how big of an impact it can be.
Absolutely. So yeah, CRS is more than a nose disease. It's like a whole life disease. And so that's one of the, I think, main things that I've learned doing this work. And brain health is sinus health. So they're all interconnected, like we talked about, and asking simple questions like, how is this affecting your life can really help you understand the condition. So if we ask the right questions, we recognize the hidden battles of our patients and what they're fighting, and treat beyond what we can see on a CT scan, I think we can not just help them breathe better, but we might be able to help them live better too.
Well, thank you so much, Aria. I feel like I was going to ask you, do you have any final pearls? The big pearl in the beginning for me was when you said basically, what is the human experience for the conditions that we treat? I mean, that's so beautifully put. But as we round it out, do you want to add another pearl at the end? Is there anything else that you'd like to include?
First of all, thanks for having me on. This has been great. But I think it just is important to recognize that inflammation doesn't just stuff up your nose. It kind of like rewires your brain. And I think the more we understand how the brain and inflammation is connected to each other, I think the more we'll understand that this condition actually is a whole body condition and a whole life disease. And I think that's something that I hope that folks who are listening in will appreciate. I think we already kind of appreciate that when we talk to these patients, but recognizing it as a real thing and telling patients that this is something that is a component of the condition and making sure they're heard can be really powerful.
Very good. Great place to land it. What do you have any, like if people want to learn more about you or reach out to you, are you on social media, or do you have a website? Or
I'm on X and LinkedIn and Doximity, the typical social media sites. But I'm also, you can easily find me on the University of Washington Otolaryngology website. I think my email address is there as well. So happy to talk to anyone who's interested in this work. It's been a journey, and it's been fun to talk about it with you guys.
Shout out to Dr. Al-Marati for connecting us.
Of course.
We love him.
He's great.
Friend of the pod.
I know. Always making us better. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Legrizio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.